treat prostate cancer, and this is the only one in East and Central Africa, the one that we have here, and we have Professor Ngugi Ngugu. He was here with us. He's a urologist consultant, and he's going to be telling us more about this new technology, as well as, you know, trying to debunk some of the myths that we have around prostate cancer. It is one that a test that, you know, people have had to rally themselves in groups, especially men, to just go for the test. But I want to find out more about it. So welcome, Prof.
Thanks.
Yes, and also you also teach at the University of Nairobi.
Yes, indeed.
All right, awesome. Yeah. So I guess the first question would be, you know, people ask about prostate cancer is what causes it. Well, first of all, for those who might not know, where in the terms of anatomy, what are we looking at when we're talking about prostate cancer?
Well, I know in one of the slides you're going to show us the anatomy of the prostate. The prostate is a pear-shaped organ below the bladder, through which the urethra passes as it goes out. So the origin of the urethra is the beginning of the prostate. It's the gland that produces secretions that allow the sperms to survive in the female vagina. So if you don't have a prostate, you cannot sire children. It activates sperm so that they are able to move once they are out of the man. So the role of the prostate is therefore to nourish the sperms, to give them mobility. So it's a normal organ. Every man must have a prostate, and it's formed about the 8th week of intrauterine life. The trouble with the prostate is that it can have a number of diseases. 3 diseases that people need to know: prostatitis, which is an infection of the prostate; enlargement of the prostate, which occurs in every man after the age of 40; and prostate cancer that occurs in many men after the age of 40. Notice the difference. There's one which occurs in every man after the age of 40. So
you say every man it is a must that it must happen?
There is one which is almost a must. 80% of the men at the age of 80 will have had it.
Okay.
So that is approaching everyone. But prostate cancer occurs in a proportion of men. The proportion of men who get prostate cancer have various predispositions. So like all cancers, the cause is not always known, but we know there is a familial tendency. There's inheritance therefore, so that if you're of African descent, you have a higher possibility of prostate cancer than everybody else in the world. If you have a relative who has prostate cancer, for African people of African extraction, we have about 3 times what the Caucasians have. When you have a relative of yours who has had prostate cancer, then that is tripled. When you have 2 relatives who have it, it is multiplied by 6.
Wow.
When you have had 3 with it, you'll get it. That's this simple thing. So if you have 3 relatives, 3 male relatives in the family who has had prostate cancer, you'll get it. Now, I don't know about prostate cancer. When research is done, is if you do look at the prostates of men who have died of things unrelated to the prostate, and you examine their prostate, you find 30 to 50% of them will have had prostate cancer cells in any part of the world. But majority of those people will not suffer prostate cancer. 20 to 30% of them will die with their prostate cancer rather than from their prostate cancer. We know it's about 10% who will suffer this disease. So there are all those things, and therefore when you're teaching and looking for prostate cancer in the population, you must look at that cancer which will be significant, which will affect your life. You don't want to treat people who will not suffer from what they have. And that's why things like PSA, examination with transrectal ultrasound and magnetic resonance imaging are so important, because you must differentiate from cancer which is important clinically and cancer that will never become clinically important. And that's the role of the urologist, to be able to tell you, yes, you may have some cancer cells, don't bother. And this way, you have cancer cells, you need active treatment. Yeah.
Alright, so basically it's all about even the prostate health, and you mentioned 3 factors. Maybe the first one that you mentioned, I mean 3 problems that one could face at any time. So maybe if you talk about the first one, the infection.
Yes.
How does one node? How does that occur?
People who have infections of the prostate, and that's not cancer, will present with either pain, frequent passing of urine, or back pain.
So when you say frequent, how many times are we talking?
Well, you're passing urine more than every hour. If you find yourself going to the bathroom every hour and less, then that's a problem. And of course needs treatment. If you find yourself having pain, some of that infection can spread to the testes. You have pain in the testes, you can have fever, you can feel generally unwell. That's an infection. That's easy to treat. Use antibiotics, then it is done. Yeah.
All right, so that's for the infection.
That's for the infection.
For the other two that you talked about, the enlargement.
Yeah.
After, you said after 40.
Yes, yes.
So what happens after 40? Is it like I think that happens after 40, or do I need to get tested before, or do I wait until 40?
You need not be bothered about it if you have no symptoms. It's going to happen in every man, so that's given.
Okay.
But a majority of the men will have symptoms of difficulty in passing urine, some waking up more than 2 times at night, or you go to pass urine and find out the urine is not flowing as it should, or you finding that you don't want to find somebody in the bathroom because you can't hold it anymore, you're going to pee on yourself. You find you don't want to find yourself in the Nairobi traffic jam when the toilet is 2 hours away because you need a Coca-Cola bottle next to you because you won't reach where you're going. That is what enlargement of the prostate is all about. And that has treatments, it has medical treatments, it has surgical treatments, and that's a different ballgame. There is really treatment for that completely, and you can even prevent its progression so that you don't have symptoms related to it in the future. What you need is care by the primary physician, and when he feels not competent to deal with it, you then need to have that dealt with by the urologist. And a lot of urologists, we're training urologists for the country, so we have urologists who can be able to deal with this problem very well.
And also just a reminder of viewers, in case you have any questions that you want to ask the good professor here, is you can use the hashtag Power Breakfast and also 22422. We'll try to sample both the SMSs and the tweets as well. So you can use the hashtag Power Breakfast and 22422. So you can go ahead and do that. You can ask your questions there and your comments as well about this. Now there's also talking about prostate cancer.
Yeah.
What are some of the symptoms? When do I need to be worried?
First of all, you don't want symptoms to come.
Okay.
If you have symptoms of prostate cancer, it's been shown world over, it will get you, it will kill you. We not use terms that are not clear to everyone. It will kill you. So you don't want to get symptoms. What you want to do is catch it while it is still inside the prostate. While it's still inside the prostate, the treatments are easy. Like the treatment we're talking about, it eliminates the cancer from the prostate. So you're cured. Don't have to bother about it. Surgery is another option. Again, you get rid of it. But if you have symptoms, and a lot of people in our world come when you have symptoms, 78% of Kenyans are diagnosed with prostate cancer when it has already spread. 78.
Wow.
So it's only a very small proportion who get diagnosed before they have spread the prostate cancer. Now at that point, the treatments are again different. They have evolved over time. We can still use this machine, but that is if the disease has only locally spread. Or you can use the machine if you have had other modalities of treatment and they have failed. For instance, radiotherapy is the burning of the tissues, if you like that term, with radioactive rays. And if you use the external beam, which is shining the rays from the outside, there is a limit to the amount of radiation that you can deliver without damaging the other tissues too much. Brachytherapy, by you delivering the seeds of the radioactive material next to the cancer, then burn the prostate cancer at that point. So you're able to deliver higher doses of radioactive activity because you're next to the lesion, as opposed to delivering it from outside, will inevitably have to burn other tissues as you go on. So you're able to deliver higher and more effective doses of radiotherapy by having the small seeds next to the cancer itself.
So then you don't want to get the symptoms. So what are the tests? Because before, and this has been, the reason why we're saying we're ending the myths around this is because before it was very hard, for men found the testing of it very invasive.
Right.
Yeah, so maybe you can explain to us how it was done before the brachytherapy.
True. The one thing that had been done before, the thing I was taught as an undergraduate and even as a postgraduate, was to put my finger in the rectum of the man and feel for the prostate. More in terms of, if it's not bad, it's not the end of the world to have a finger put in your back end, but people, probably felt uncomfortable. We still need to do that, but not with this machine. You probably don't need to. But the PSA test is a very useful test of looking for prostate cancer. It is very sensitive in picking cancer cells, but it's not very specific. So once you've done a PSA and it's elevated, the next thing to do is something new again around here, and Nairobi Hospital has some of the best, and that is the MRI. Once you have the MRI done, we know now that if the PSA is risen...
So the PSA is blood, you draw blood?
You draw blood, 5 cc's of blood, goes to the lab in 2 hours, you know whether it's high or not. Okay. Then if we find it is high, we send it for MRI. Go for the MRI examines. If it says there is no lesion, then we have to debate whether to biopsy or not. If it says there is a lesion, then we can see it on MRI, and we can combine the picture from the MRI to the picture that takes the biopsy, so that we take specifically the lesion which we think has cancer. And that, well, we still take a biopsy, we're taking more with precision, because we know that where we are going to take this biopsy. So not only that, and if we have to take what would be called many biopsies without guidance from the lesion that you saw, again you can plan this very well, so that you make sure you have biopsied every part of the prostate, so you don't leave any cancer behind. So you're able to tell the patient with certainty that I know you don't have cancer. As opposed to the situation we have taken biopsies, and we repeat biopsies, and eventually we find cancer, because we are hitting different parts of the prostate. So the good thing about some of these machines is enabling you to map where you're going to biopsy, how much you're going to biopsy, and you get the real thing. You're able to get the prostate cancer, and you can say with 95% confidence that you have excluded prostate cancer. Once you've diagnosed the prostate cancer, the story doesn't end there. You've got to decide, this cancer that you have, how aggressive is it? And in the past we've talked about Gleason score, and we still do, but now we're talking about groups, and perhaps that is easier for members of public and lay people to understand. We have group 1 disease, which, because of what we said at the beginning, that some prostate cancers may not need to be treated, we can actually observe. We can actually follow you up and see what happens to you, and see whether the PSA is rising, and see whether the disease is becoming aggressive. So disease 1 has an option of treatment or no treatment at all. Group 2 disease must be treated. Group 2 disease we know will progress, and that's the disease, if you get very early, if you have it at a stage 1 or a stage 2, A and B, you can actually get rid of the disease. Surgery has been described as the best, but surgery has its side effects. External beam radiotherapy is also good, but external beam radiotherapy causes a lot of issues. It may cause strictures, it may cause erectile dysfunction, and it may also cause problems with bleeding. Brachytherapy, on the other hand, by being so targeting, may eliminate all those problems, or majority of those problems, and that is why brachytherapy is so useful. No surgery, and the treatment is 1 day.
Okay.
The treatment, the external beam radiotherapy, takes 6 weeks. This one, you go to theater 1 day, the seeds are put in the prostate, and you go home. We follow you up and see what happens. What about the patient with recurrent disease? You've been treated with external beam, or you've been treated with various other options, and you found that there is still some cancer, or some cancer has recurred. Again, you aim specifically at that recurrence point. You put the seeds at the recurrence point, and you can be able to control that disease, or even indeed eliminate the cancer at that specific point. That's why it's so different. That's why it's so transforming, because it's a day treatment. You're in hospital for a night, and as we proceed, perhaps we'll be doing patients as daycare.
And what are some of the causes, apart from age, getting to 40 and it happens naturally? What are some of the causes of of this?
There are many things that have been looked at in terms of prostate cancer. Of course, the issues of prostate cancer, diet has been mentioned as one of them, and there are indeed dietary provisions that may prevent prostate cancer. Certain diets are said to be less causative of prostate cancer. For instance, we know that people in the Far East, the Chinese, the Japanese, and people from that area, have the lowest incidence of prostate cancer in the world. But when they move from there to our side of the world or to America, they start acquiring the same rate. So there's something environmental about prostate cancer. We also know even in a country like Kenya, there are some parts which have more prostate cancer than others. We know the region around Mount Kenya tend to have higher and more aggressive cancers than the rest of the people. So again, there must be environmental factors. So diet is important. Sexually transmitted diseases certainly have a role, and we think by causing infections of the prostate may lead to you having prostate cancer. So people who get recurrent infections, sexually transmitted infection, would have that kind of problem. The other thing that we need to think about is people who are immunosuppressed. We see this very regularly. Patients who have had kidney transplants, for instance, and have necessarily got to have drugs to keep their kidney, tend to have higher prostate cancer. People with leukemia, people with HIV, and so on, tend to have more aggressive cancers and cancers that are difficult to treat. So basically, we can keep away from this by lifestyle, perhaps. We think that the eating of meat and meat products probably is not a very good thing for prostate cancer.
So this, what kind of meat? Because there's somebody here actually, James Livingston, is asking, can prostate cancer be caused by the kind of food we eat?
Indeed it is, and we're saying that red meat is not a very good thing for the prostate, and you may have that it predisposes you together. Take it in moderation. Big quantities not good for you. Take only what you need to eat, not 1 kilo of meat a day.
Okay. So it can be caused by that as well. Yes, actually somebody is also asking again, his name is Kungu Karaoke, is asking, how can sexuality and sexual activity affect the infection of prostate cancer?
There's a very good study that was published 4 years ago that showed very interesting things: sexual activity and prostate cancer. We know that young people who engage in a lot of sexual activity have a higher risk of prostate cancer, while older people who engaged in more sexual activity with single partner had less prostate cancer. So if you're going to have a lot of sex with a lot of people, you're predisposing yourself to prostate cancer. But if you have a lot of sex with one person, then you have less prostate cancer. That's the way it is. But I suppose that's the way nature wanted it. So if you have a lot of sex with a lot of people, you're in big trouble. But if you're having a lot of sex with one person, then you're probably safer.
Yeah, all right. All right. So we still have some more questions coming in as well. But even as, just remember, you can keep talking to us using the hashtag for breakfast or SMS line 22422. Right now we're checking the hashtag. We'll be going back to check some of the questions as well on our SMS platform, but now we're on the hashtag. And Kipigan Rogo, I think, has just tuned in, and you say that when you're getting symptoms, it's too late. You shouldn't wait for the symptoms.
Don't wait for the symptoms,
because he's asking what are the symptoms and the signs.
They're there. The back pain, there is pain passing urine, difficult passing urine, your kidneys are blocked, but by that time the horse is out of the stable.
It's a little bit too late for that. All right, so even as we're going to, I see so many questions coming in, but I want to talk about this machine as well in a little while, and just to explain more about it. But even after that, you say there's you mentioned something about it recurring.
Yes.
So when it recurs, what do you do?
You see,
or how do you know?
Let's talk about how recurring occurs. For instance, you come with prostate cancer, with early disease,
right,
and you get external beam radiotherapy, and we promise you we have cured you. But 3-4 years down the line, 5 years, 6 years, your PSA starts rising. We check and we see there is, yes, indeed, a recurrence somewhere within the prostate, because external beam by itself is not necessarily curative. So we then say, we can't give external beam radiotherapy anymore because the tissues cannot handle that. So what we're going to do is deliver the radioactivity at that lesion, at that recurrence. So we will be aiming at that recurrence with this machine. So you go specifically to whether, so it is as a targeted therapy rather than bombing therapy. Is a targeted therapy of the specific place.
All right.
And that can cure you again.
Okay, so I want us just to explain, to just walk us through what you have.
Yeah, true.
A little bit on the side here.
Indeed, and this is the brachytherapy machine. It's pretty magnified at this point. But basically when we're doing, this is a brachytherapy machine, but it can also be used for biopsy. Not just for brachytherapy, which is treatment, but it's also used for biopsy. There's a lot of magnification. We do this under ultrasound. There's an ultrasound that will be showing us on this, and you're seeing this is ultrasound image of the prostate that we are seeing there, and that image is transferred to that laptop there, and that assesses what part of the prostate we are going to either biopsy or what part of the prostate we are going to put the seed of the radioactive material. Then for us to put that, there is a grid. This with so many holes is a grid. It is now superimposed on that. So you can actually see the image of the prostate versus the grid. And the person sitting on the computer there tells you, we want to deliver so much energy or radioactivity at point X. So you go through any of these holes, there's A, B, C, D, small a, small b, and then you aim at that. So you are very specific, you've got coordinates, and those are the coordinates that you're going to use either for biopsy or delivering the seed. So you place the needle at the point where you need that radioactivity or you need to biopsy. Once you've done that, this of course are placement of the patient. Patient would be necessary at the general anesthesia, legs apart, and we go in this in the perineum. This is put in the perineum, so it fits very nicely. We use X-ray as well to be able to tell the position of the bladder, the position of the prostate, because as we do this, there are things we need to do. We need to protect. Remember, we're talking about tissues that need protection. We need to protect the rectum. The prostate is next to the rectum. We don't want the rectum to be injured. The prostate is next to the bladder. You don't want the bladder to be injured. The urethra passes through the prostate. That's the urethra. You must keep a certain level of radioactivity away from the urethra, otherwise the urethra will be damaged. So once you've done that, patient is asleep, you position yourself there, you can see the prostate, and you move from the highest part of the prostate to the lowest part of the prostate, and I'm sure we shall be showing that in the next picture. So once you have done that, once you have delivered the seeds of the radioactivity, patient is treated, patient wakes up. We put an indwelling catheter, that is a urethral catheter, to drain the bladder, because we're going to pass in a lot of needles as we pass through, because we're going to do, wow, all these holes are delivering needles. So you deliver so many seeds of the prostate, seeds of the radioactive iodine into the prostate, and that will cause a bit of injury to the prostate. So the prostate gets swollen and you may have difficulties passing urine. So what do we do about that? We put a catheter for 24 hours. The following day we remove the catheter. We will also need to keep you away from other people for that 24 hours, because you are emitting radiation. Because the radioactivity is, but not for people, only for people who are like a meter next to you. After another 24 hours, you're not a danger anymore. But in the first 24 hours, we need to put you away from other people, so that you are the only one who is carrying the radioactivity, and you're not taking the radioactivity to other people. That's specifically the reason why you want to keep the patients in the hospital for maybe about 8 hours. But because 8 hours translates to a day, so we keep you for 24 hours. So once that is done, that's it. So this is a bed or an operating table that has an ultrasound, that has a computer and that computer has software for deciding how much radioactivity you need to put where. So it's very precise. If you're going to burn the urethra, it calculates for you and tells you, no, move away from there. If it's, or reduce the dose. If you're going too close to the rectum, it tells you, no, don't go there. So that software guides how much radioactivity you deliver. So it's more specific than we do the external beam, where you burn like this, without knowing what you're going to burn. And you do know, but within certain limits. But this is within a few millimeters distance of that thing. So that's why it is so useful, and it helps. It's something that makes it easy for you to have the treatment. You can come have a treatment within 24 hours and you're done. And you don't have to have trouble with your urine, you don't have to carry catheters, you don't have to. You're basically okay by the time.
So after that, maybe.
Yeah, sure.
After that, is it still? Is there? Most people wondering about the pains and all that. So, what are you experiencing? Discomfort after that?
My experience with patients is that the discomfort is as little as that of having a catheter for those who have had it. It's very, very simple, and you find that after 24 hours, you have no problem whatsoever. But because the prostate is still swollen, we also give you some drugs that widen the urethra to allow you to pass urine without difficulties. Because if you don't give that, sometimes people may experience difficulties passing urine. But once we've done that, that's it. You don't have any more trouble, and you're basically in 24 hours. It's like you went to the supermarket.
Right, and you're back.
And you're back.
All right. So, of course, there's still some more people here who are asking questions. Somebody also saying that he's saying you're very learned. So that's a plus as well. Yes, and also, now, somebody asked after the treatment, this is Ben _ something, but he's asking after the treatment, what about his diet. Basically, asking about his diet after the treatment.
Well, nothing changes. Basically, your diet doesn't change, your sexual activity doesn't change, and nobody notices you've had this treatment.
The treatment, yeah.
And you don't notice as well. In 24 hours, you're home, done. There's nothing to worry about. Yeah. So
right. So that is important for the men to know. And then, so generally, to keep the prostate healthy. We know what not to eat, but what should we ideally eat, and what should be our habits? Is exercise involved? What
exercise? Yes. We said lifestyle key.
Right.
If you've got good lifestyle, you keep cancer away. Don't get stressed up. Don't get stressed out by your marriage, by your bank account, by your mortgage, all those things. Yeah.
By January.
By January, all those things. Those will increase your possibility of getting cancer. Be happy, be jolly, talk to people, laugh. That will take your cancer away. So that's lifestyle. Go jog if you can. If you don't have a treadmill, probably jogging is better than a treadmill. So work out, jog, be happy, sleep well, sleep at least 6 hours. And you're good to go.
You're good to go. No, so, what will your message, to the men? Because part of what we're trying to do today is to get more men. Like you said, if you said 78%, that's a huge number.
Yeah. 78%
of Kenyans, Kenyan men. So, what would be your message to them in terms of going out? And you probably are 20-year-old and is watching and thinking, he said 40, so I can relax, or a 40-year-old is also watching. What would be your message to them?
Let me put it this way. I don't want to scaremonger.
All right.
But I will tell people like this. 1 in 10 people, 1 in 10 men will get prostate cancer. So if there's 10 of us here, 1 of us will get it. That's a big number. And in Kenya, 78% of those will be diagnosed when they are going to be killed by the disease. So 10% of the people will die from that cancer. 10% of the Kenyan population of men will die of prostate cancer. Preventable things. When we talked about the diet and all those things. And then the testing. There's issues about what time you do your PSA. And now we're advocating what we call the index PSA.
I just remembered, for those who don't know, what are you looking at? What is the PSA for?
The PSA is prostate specific antigen. It is a test that is very sensitive for prostate cancer. It may not be very specific, but it's very sensitive. So it's able to collect all the people who are likely to have prostate cancer. And then we take the ones who we are worried about through the other investigations that will tell us whether we need to take a biopsy or not. Once we know that, then we treat. So the message from many urological associations and the leading urological associations of the world is that you must have an index PSA. If you're from a community that has high risk of prostate cancer, maybe Kenya, that is one of such countries, then you can bring the 45 to 40. You do your index PSA. But that's a very important message that has come in the last 2 years. That this index PSA, if your index PSA is less than 4, nanograms per ml. You do not need to do another PSA until you are 54. So you don't have to be doing it every year, right? Just that one PSA. You've reached 40, 45, between 45 and 54, please do one PSA in that one decade. Thereafter, the testings need to be more frequent. But between the ages of 45 and 54, for those 10 years, just one PSA. We're not asking you to do 10 PSAs. We're not asking you to do annually. Just one index PSA will save you. So that you don't come like a classmate of mine say, I saw you on TV the other day talking about prostate cancer. Can I have a PSA? We did, and we found he had metastatic disease and he was dead in 2 years. So that's not what he was my classmate. Yeah, that's not what we want. We want you to come when you're smiling, you're happy, and we come in just have a check. We check. We say, yeah, there is a small thing that needs to be sorted out, and we're able to sort out this way without even having to mutilate you with surgery. Yeah.
So if you are between the ages of 25, 35,
have it happy. Except watch the organ between your legs.
Yes. Focus with one.
Yes.
That is a take on that.
Yes.
Well, let's say a big thank you to Professor Mungai for coming. Of course, a conversation that we will continue to have as much as is possible to get more people to learn about this and to get more men, especially like you said, 40 to 45 out there, and to get those who are not yet there, you know, to go ahead and find that out as well. But one last question, which of course everybody wants to know, Guitar is asking, how much is a PSA test?
PSA test varies from one part of the country to the other, but on average in the public hospitals about 400 to 500 shillings, in the private hospitals between 1,500 and 2,500. So really it's about 3,000 shillings at the highest end and 500 shillings at the lowest end. So it is doable, and I think the more PSAs we do, the more likely we are to probably bring the prices down.
All right, so there you have it. That's Professor Mungai Ngugi, who's a urologist, also teaches at Nairobi University. Of course, we thank you so much, University of Nairobi. Thank you so much for coming. We'll continue to have this conversation as well. I hope you're informed. I hope you'll take action as well. Remember, now it is non-invasive. You can go ahead and have your test done and do your PSA as well. Let's draw the blood. Alright, well, I'd like to thank you for all your comments. I know some of them we were not able to answer questions, but thank you so much. The hashtag for our breakfast, and for those of you who are talking to us on 2242, we say thank you so much. On behalf of Joy Mudengi, my name is Ulu Saburu, reminding you as always that successful people look like you, and of course the great Manchester United. Have yourself a wonderful Tuesday, and look out for Artisan TV Kenya for what will be discussed later on in the evening.